So let's talk briefly about the way these patients present in the emergency department and ICU. What is their clinical presentation? What is the clinical presentation of the patients of the acute ischemic stroke? So the clinical presentation comprises of clinical presentation of these patients comprises of history and physical examination. So the history of these patients or the symptoms of these patients depend upon which area of the brain is involved. Let me make the diagram of the brain. If we have it, this is frontal lobe and this is, okay, it's a rough diagram. This is the frontal lobe. This one is the parietal lobe. And this one is the occipital lobe. And this one is the temporal lobe. Temporal lobe. Now, underneath this cerebral hemisphere lies the hindbrain of the patient. If I make it here, like this is actually temporal lobe. Temporal lobe. Now, in this part of the brain, here we see, if this is the midbrain, then comes the pons, and finally medulla, and here it goes as the spinal cord. So this part is actually brainstem, and brainstem comprises of midbrain, pons, and medulla oblongata. Medulla, and this is midbrain. And behind or along with this we have cerebellum. There are two hemispheres, like the hemispheres of the cerebral cortex. Cerebellum has got two hemispheres. So I am making only on this side, this is cerebellum. Cerebellum. Now, when we talk about the clinical symptoms of the patient who is presenting in the emergency department with a suspicion of having acute ischemic stroke, it largely actually depends upon which part of the brain is affected by occlusion of the blood supply in which cerebral artery. For example, the medial side of the frontal lobe and the parietal lobe is affected by the involvement of the anterior cerebral artery. Anterior cerebral artery. When anterior cerebral artery is involved, mainly the frontal lobe and especially the medial side of the frontal and anterior and medial part of the parietal and anterior and medial part of the temporal lobe are involved. So our personality is actually comprises of these frontal lobes. So when there is involvement of the frontal lobe and the anterior cerebral artery, then there are symptoms related with the personality changes of a person. And moreover, in the frontal lobe, motor activity of the legs are actually controlled. So the weakness of the lower limbs is more associated with the anterior cerebral artery involvement, but with the involvement of the middle cerebral artery, upper arm weakness is major manifestation of the obstruction in the middle cerebral artery. And middle cerebral artery basically supplies the larger lateral surface of the parietal lobe and anterior part of the temporal lobe and anterior part of the occipital lobe. But the brainstem and cerebellum and occipital lobe and also the thalami, they are supplied by the posterior cerebral artery. So posterior cerebral artery involvement will cause those manifestations which are actually controlled by the cerebellum and the brainstem. For example, if the cerebellar branches of the posterior circulation are involved, it will cause ataxia and vertigo and nausea and vomiting. And if there is involvement of the brainstem through the obstruction of these perforating arteries from the posterior circulation, then there will be problem with the conscious level of the patient because of the involvement of the reticular activating system area. And if the posterior circulation is involved, there will be blindness because of the occipital lobe involvement. But in cases of the anterior and middle cerebral artery involvement, the majority of the patient, they present with the contralateral weakness of the upper or lower limb. And in case of the anterior cerebral artery, this is the lower limb is involved. And in case of the middle cerebral artery, it's the upper limb which is mainly involved. There may be loss of sensation on the opposite side of the body, and there may be involvement of the same side of the nerves. There may be homonymous hemianopia, and there may be involvement of the facial nerve on the same side. So if we just write down what are the major symptoms of these patients, how these patients actually have presented in the emergency department, then all in all, these are actually, number one, it would be abrupt in onset, because there are certain situations that can mimic the stroke. They are known as stroke mimics, and we will talk briefly about them. But here, these patients present with contralateral body weakness, or hemiparesis. For example, if left side of the brain is involved, if I make these two halves of the brain, this is the axial part, axial actually view. These are the ventricles. So if the one part of the brain is involved because of the vascular obstruction, the manifestation of the weakness will be on the opposite side. So there can be contralateral half body weakness, which are the hemiparesis. In case of the anterior cerebral artery, lower leg weakness is prominent, and in case of the middle cerebral artery involvement, it is the weakness of the upper limbs. So there can also be loss of sensation of the opposite side of the body, opposite half of the body, contralateral sensory loss, or we can also get dysesthesia. So it can be involvement of the homonymous hemianopia or hemianopsia. Half of the visual field is gone actually. Homonymous hemianopsia. Hemianopsia. If this is the visual field, patient may be looking at this nasal part, but both the temporal visual field are gone. So patient is looking at the half picture, and the half picture may be off the sight actually. Third, there can be involvement of the facial nerve of the same side, ipsilateral seventh nerve involvement. This is known as crossed hemiplegia. This is known as crossed hemiplegia, where the nerve of the same side and muscles of the opposite side are involved. So There can be contralateral body weakness, contralateral sensory loss, homonymous hemianopsia. There can be ipsilateral seventh nerve involvement, facial nerve palsy, and then there can be aphasia. Aphasia, patient may not be able to speak, it may be receptive, it may be motor, or it may be global. Again, it depends upon the involvement area of the brain, because in the frontal lobe, on the inferior side of the frontal lobe is the Broca's area, which is involved in the expression of the speech or the motor part of the speech. And reception of the speech is through the vernix area, which is located in the superior part of the temporal lobe. So patient may not be able to listen properly, which is known as the receptive aphasia. Patient may listen but cannot be expressive, cannot make words, or cannot use the tongue to actually speak. It can be motor aphasia, or it can be involvement of both the receptive and motor part, which is known as the global aphasia. Again, the part of the brain and the part of the arteries, cerebral arteries involved are actually important in this thing. So this is what happens when the left side of the brain is involved, which is called the dominant hemisphere. Left cerebellum involvement causes aphasia, because the speech areas are located on the dominant side, which is the left side. Left cerebral hemisphere involvement. Left hemispheric involvement. Hemisphere involvement. It causes aphasia. Then there can be a complaint of neglect of the half part of the body. Neglect half body. In case of right hemisphere involvement. Or non-dominant hemisphere involvement. Left-sided hemispheric involvement actually caused the aphasia or the dysphasia, either the absence of speech or the difficulty in speaking. But if the area of the involvement of the brain is the non-dominant hemisphere, which is the right-sided hemisphere, then patient may not know that half of the body area is present with him or her. So there is neglect of the half body part in cases of the non-dominant involvement. So there can be in cases of the involvement of the posterior circulation and the cerebellum, there can be ataxia, complaint of patient is not able to walk properly. There can be complaint of vertigo. There can be complaint of nausea and vomiting because of the involvement of the chemoreceptor trigger zone area, which is located in the brainstem. Nausea and vomiting. So these are the majority of the patient, they present with these complaints, and this depends upon the area of the involvement, and the patient comes in the emergency department, gives a history, or the family gives the history. Now this is very important point to be remembered, that when you ask the family and the patient is not able to speak or patient is able to speak, you ask them, when did it start? This is a very important question, because sometimes family is giving you the answer that when they had seen the patient last night, when the patient went to the bed, and he or she was found in this state. So that last time when patient was seen will be the time zero, and you will think that this problem started right at that time when the patient was last seen normal. So they may give a history of weakness of half of the body part. There can be a loss of sensation in one part of the body. Patient may not be able to see completely. You can check the visual field, that depends upon on the physical examination. There can be drooling in on one side. For example, if mine right facial nerve is involved, then I'll when I'll smile or I'll try to talk, or when I'll be just doing any activity, the normal part will go high and this will just drop. So that would mean that I have developed a right-sided weakness of the my seventh nerve. So there may be ipsilateral facial nerve involvement. Patient may not be able to speak properly or speak at all, or may not be able to listen even, depending upon whether the aphasia is or the dysphasia is receptive, motor, or global. There may be a patient may not be aware of the existence of half of the body part because of the involvement of the non-dominant or right hemisphere, because in majority of the people left dominant is the left hemisphere is the dominant hemisphere. If the brainstem is involved, there can be the problem of ataxia. Patient may be having vertigo. Patient may not be able to maintain the balance. There can be nausea and vomiting. Patient may be actually looking at things and telling that he's looking at a couple of things or pair of the things, diplopia, double VN. Again, because of the involvement of the brainstem, because it has got the nerves present over there. So this is the clinical presentation of the patient. Now, what is the physical examination of the patient? Now, in the physical examination, we should remember a very important scoring system which we call the Rosier score. Majority of these patients do not present with the loss of consciousness, but if they present really late, there may be a loss of the consciousness. But let's see what we see in the physical examination. Physical examination. Now there is a very important scoring system which we call Rosier score. Rosier score. So how these are numbered? Contralateral. Now we are checking the patient. Contralateral, sensory loss, is given +1. Contralateral motor loss, is given +1. Contralateral arm weakness is given 1 positive. Contralateral leg weakness is given 1 positive. If there is a seizure, it is given 1 positive. But if there is a loss of consciousness, it is given 1 negative. And if there is speech loss, it is given 1 negative. Speech loss, 1 negative. So normally it ranges from -2 to +6. -2 to +6. The Rosier score normally is -2 to +6, but whenever the score is more than 0, we call that there is a strong suspicion of the presence of the acute ischemic stroke. So Rosier score is a way to know for the emergency doctor the presence of acute ischemic stroke in any patient. If the score is more than 0, then it will be a strong suspicion of the acute ischemic stroke. Now, while checking the patient after the ABC, obviously whenever you receive these patient in the emergency department, first you will always do the airway breathing circulation, because these patient do have disturbance of the conscious level sometimes. So always try to check the conscious level in them. In physical examination, we do the pronator drift. Pronator drift. In the pronator drift, we ask the patient to close the eyes and outstretch the both arms, and then just keep them like this. And in the affected limb, patient will not be able to maintain it, and it will sway away from the central position. So this is known as a pronator drift, and a very strong suspicion will be of, if it is a positive, there will be a very strong suspicion that patient has got acute ischemia of the brain, because it shows the focal deficit. So there can be Romberg sign, or you can check the gait of the patient if you have the suspicion that there is an ataxia. So you will ask the patient to close the eyes and just walk on a straight line. Patient may not be able to do it. This is also another sign for for presence of the acute ischemic stroke. Ataxic gait. Ataxic gait. In the physical examination, you can also check the sensation of the patient to see if there is loss of the sensation in the patient. And you can also check the visual field. You can check the visual field of the patient to find the hemianopsia. So other than the visual field, you can also check the facial nerve or the eighth nerve. Facial nerve to find the facial nerve palsy, and vestibulocochlear nerve can be checked. Vestibulocochlear nerve check. With the help of the tuning fork, you can actually assess the patient if there is involvement of the any nerve. Then you can also check the swallow test. This is another very important test to actually understand if the patient is able to swallow or not, because there can be, in cases of the posterior cerebral artery involvement, there can be involvement of the 9th and 10th nerve. 9th is the glossopharyngeal nerve, and 10th is the vagus nerve. They are involved in the swallowing process. So if they are affected and patient is mistakenly given some food, patient will aspirate the contents into the lungs, and this can be a huge problem for the patient. So this is always a very important to check the swallow test in these patients.